Picture a normal doctor visit, a checkup, a blood test, an x-ray. Now, every one of those goes to insurance, a claim, maybe a prior authorization, maybe a denial. We don't do that with a car. Your wiper breaks, you don't call your insurer. You just buy the wiper. Here's the thing. Insurance should be there for the big stuff, the emergency, the surgery. But a blood test, a sore knee, why is that running through insurance at all? My guest today is a frontline physician who got tired of watching the paperwork come between his patients. So he built something different. So today we're exploring two questions. What is the current healthcare system doing to the patient? And what if you kept insurance only for the catastrophe and pulled it out of everything else? David, welcome to the Hub Brief. A physician who wants insurance pulled out of everyday stuff. That's not something I hear often. 25 years on the floor, almost 100,000 patient visits from ER to primary care. You've seen this from sides that almost no one ever has. You came in as a doctor who got tired of what he was watching. So before we speak about longitude and the model that you're building, I want to start with you. You've been that patient too. So talk to me about your journey. I remember you saying that you broke your back. Take me to that day.
I want to start by saying thank you so much for having me on your podcast, AJ. Love what you're doing. Yeah, as a physician, obviously, I can talk a long time about my vantage point there and what I've experienced over the last
Yeah.
25 plus years. But just like others, I'm a patient too. And in January of 24, I had a ski accident, just unfortunate fall that ended up with
Hmm.
what's called a T7 chance fracture. I had to go to 3 different locations, ultimately ended up in Denver, where they did surgery the next day to do a 7 level fusion. It was a
Hmm.
major medical event for me. And it was exactly what insurance was created for. I was thankful to have catastrophic insurance coverage at that point because without it, it would have been extremely difficult to
Hmm.
pay for that. And so I experienced that on the patient side, all the EOBs, all the
Hmm.
back and forth with the cost affiliated with that, all the different levels of cost, everybody touching the healthcare dollar between the premium and the provider.
Yeah.
And I'm a big fan, as you've already alluded to, of insurance not having to be involved at every aspect of healthcare.
Yeah. And so insurance earns its keep in a catastrophe, right? As you said. But when did you start asking, why is it showing up on my blood test, right? So walk me through what went through your head. I mean, if you look at the numbers, 33% of US households, they delay care because, the cost is way too high. An average family spends $25,000 in premiums. So, do we even use that insurance for blood tests or x rays, right? So, walk me through what switched in your head and say, I understand I broke my back. I need this, but do I really need this for a blood test or an x ray?
Absolutely. When I finished residency, went out into private practice, I immediately started having some thoughts as to there has to be a better way to do this, to see a patient for an elbow issue that took literally just a
Hmm.
few minutes to say, here's what it is, here's what we're going to do to treat it. It just made no sense to have insurance involved at that level. This was outpatient primary care, had thoughts of direct primary care type models. A long time ago, there were people like Garrison Bliss and Q Alliance out in Seattle that had started
Hmm.
doing that in the 2000s. And then Jay Parkinson, MD out of Brooklyn, started developing a model and software attached to saying,
Hmm.
just pay a monthly fee and we can provide all your primary care services. And they made this work. I did some concierge medicine for a while. I had people that knew me and knew what I did and said, hey, we want to pay for this. And to be honest, I didn't feel like I was solving any problems for healthcare doing concierge medicine for the people that need and want that. But for
Yeah.
me as a physician, I felt like there's a way to touch more lives, help more people. And so that direct primary care type thought process started a
Hmm.
long, long time ago for me and supporting organizations like Primary Health Partners, which is a 30 plus group, physician group here in
Hmm.
Oklahoma that's having incredible success in DPC. It got my wheels turning about 10 years ago. Perhaps it doesn't have to be just
Hmm.
related to direct primary care. Perhaps we can extend this model.
Yeah. And switching back to the from a patient's perspective, as you said, right, that you're doing this for the patient. And then I remember you mentioning the call, actually gotten worse. I mean, I put out the numbers before, right? 58% put off care over cost. Now, because people skip care, and this is what, people like you are trying to have a conversation around, is even people with full insurance, like Cadillacs of insurance, and we'll go through sort of a thought exercise down this podcast. But from your experience in the exam room, right? So you see a person coming in. How do you have that conversation, right? They don't know the cost.
And
What's gotten worse for them?
so deductibles have gotten worse. In an effort to level off premiums, insurance companies
Hmm.
have had to increase deductibles. And this is a cycle that insurance companies go through every so often, maybe every 3 to 5 years, where
Hmm.
deductibles get too burdensome. And so they have to start increasing premiums. And so it yo yo's back and forth. Well, when you start to look at concepts like direct primary care and what we're doing, direct specialty care, what you're doing is saying, okay, we're going to remove the friction between the patient and the provider. So you don't have to deal with all the EOBs. You don't have to deal with
Hmm.
adjudication of claims. You don't have to deal with all the touches that happen currently between every aspect of healthcare. I've experienced healthcare in numerous platforms. One
Hmm.
that's been interesting over the last few years is covering critical access need hospitals. So I go to these hospitals, many of them, they're very rural, and work with a lot of wonderful people in these locations. But I see a lot of patients. Medicaid's a really bad example of this, but a lot of patients that don't have good access to care, can't get in to see a specialist. And because of that, that problem ends up becoming something that becomes urgent or worse, emergent, or they simply are just tired of waiting and they want to
Yeah,
get it dealt with. And so they end up coming to the emergency room, which is the worst place to go from a cost
exactly.
standpoint. Emergency rooms are the highest cost center in healthcare, right? So we
Yeah.
don't want patients getting primary care. We don't want them getting routine, predictable aspects, especially surgical care. We don't want them ordering labs. We don't want them getting imaging through an emergency room because
Yeah.
that is just inordinately expensive. But we want patients to be able to have access to care properly so that those costs don't balloon for the insurance company, for the plan.
And we will talk about the insurance companies and the plan, right? And how they go through this exercise. But, and focusing back on the patient, you're absolutely right. I think the delay is denying access to therapy and using emergency room to do anything but a catastrophe work is a misuse of resources, right? And you alluded to about this in our conversation previously, is that you said that the delay itself is a business model for a lot of companies, right? That a prior authorization sitting unapproved is an extra month that's parked in 25, 50 grand in a bank account earning interest. And if you look at the same question from a perspective of a CFO of an insurance executive that says that prior authorization is to stop fraud and abuse, right? I mean, we want to make sure we take our time to approve the right process and procedure. You're a doctor. Is any of that true?
When prior authorizations are handled correctly, they can be an invaluable tool. I'll use the example of high cost medications, medications for cancer care, for rheumatology. Some of these can be incredibly expensive. So I do think that there's a process that needs to happen to some degree to say, okay, is this the best medication for this situation? So and that may come from someone like a primary care provider like myself. Well, I shouldn't be prescribing oncology type care,
Hmm.
oral chemotherapy to a patient. That really needs to come from an oncologist, and that needs to be done in the right way. But those are the exceptions, not the rules. When prior authorizations happening at so many different levels, and it's an automated system where if you don't check any number of a
Hmm.
dozen boxes just the right way, it kicks back. That
Yeah.
creates delays in care, and the patients really are absolutely the ones that lose when it comes to the prior authorization game that is happening every day. And
Yeah.
I've been on that side of it as a physician. I've been on that side of it even as a patient, but more so as a physician dealing with the hassles of it. And the answers, we get as providers is, well, you have a prior auth. We just need you to jump online through this link and do this prior auth. Well, that may take 10 or 15 minutes to do that.
Yeah.
That's 10 or 15 minutes more away from our families, from our patients, from other responsibilities that we have. And I will tell you, 9 times out of 10, it is a colossal waste of time in my experience, at least on a
So
primary care level.
yeah, and I understand the primary care level, and I think I spoke about this last time we met. Remember, I told you about this story about a surgeon in Texas. She had a breast cancer patient under anesthesia, and the carrier was calling in to get the prior authorization. She was like, "What do you want me to do?" Right? And then she gets gap clause saying you can't speak up. So 85% of those authorizations are run through AI now anyway. So,
Mhm.
when the denials in an algorithm, the patient's already under anesthesia or going through a process, who's accountable in that situation, right? Is it a provider or is it the insurance executive? Is it a clinic admin team? Because as you said, 13 hours per week on just the admin costs for providers. And you multiply that with complex cases and rare diseases, you're spending $53 million. dollars. Medicare Advantage prior authorization requests cost $53 million a year, and 80% of them get overturned anyway. So the point is, you're trying to solve the system for the patient. So if you keep patient at the center, like I always say, even in my strategy conversations, right, with the healthcare executives, saying, if you keep patient at the center, the insurance company is going to say, I'm going to take a more humane approach and understanding when a prior authorization is and isn't required. I'm going to work with the provider's offices to figure out how I can reduce the friction to the patient and their access to therapy. And then you will talk to specialists in this area and say, how can I get appointments, not 6 weeks down the line, but 2 weeks at max to get you in to see a specialist without you double guessing how much it's going to cost you, when you're going to get in, and how you're going to get access to therapy, and literally just go through the problem like, like the way this country should. And our healthcare system should support that patient, right? So the admin burden is just beyond complicated. And that's my next segue into the complexity by design, right? Who created all this? Why is it still here? Everyone agrees that it's broken, right? You call it complex by design, but it should be built for the patient, but it's not. So who is it built for? What do you think?
Well, I think a simple answer is the current system's built for the insurance companies, the large players that
Hmm.
control so much of the healthcare dollar in the U.S. If I bill a Medicare patient, although I'm not going to get paid near as much for seeing that patient as I would for a large insurance company patient or a
Hmm.
private insurance company patient, I'm also going to get paid fast. A Medicare system is set up to where you get paid every couple of weeks, and
Hmm.
it's pretty predictable revenue, right? The insurance company, it's not like that. As soon as that claim is generated, it is having to jump through one hoop after another. And that's where the friction is on the processing of the claim side that is so convoluted, complex, unnecessary. And then
Hmm.
there's so many people touching that healthcare dollar again from the time that the claim's generated until the provider finally gets paid. The friction is enormous for the patients as well.
Hmm.
If you think about what patients have to go through from the time the primary care physician says, I want to get in to see an orthopedic surgeon and you might need an MRI. Well,
Yeah,
that sounds pretty simple, but the system currently makes that very convoluted and complex and unnecessarily so. These are routine aspects of healthcare. These are very
exactly.
normal, predictable aspects of healthcare. Uh, it's one thing, AJ, if I say, "Hey, your knee's a problem. I think you need to go see an
Yeah,
orthopedic surgeon," and they may be ordering an MRI, your X-ray shows some arthritis. I'm going to put you on some Celebrex, whatever example you want to use, and then you go see the orthopedic surgeon, get the MRI, and then all the insurance stuff kicks in, and you're getting all this paperwork back and forth, and having to sign for it, and have you made your copay, have you met your deductible, all these things. Now, there's some really good models that are happening within the same paradigm in which we're operating of direct contracting, where they're
hmm,
eliminating copays and deductibles. I know a lot of forward thinking plans right now, and there's a lot of great people, innovative people trying to streamline healthcare in this way, especially on the employer sponsored insurance side of things, where they're saying, hey, we have direct contracts. But the problem I still have with that is it's still living in a fee for service world. You have to have it. If you're an employer and you have employees in 5 different states, you can't just pick a narrow network in one state, right? But the fee for service model kind of goes back to what you were talking about is
yeah,
what's one of the problems here. Well, the insurance companies don't really trust providers to say a patient needs this. And so
yeah.
we're going to make sure and put your feet to the fire that you do need that. And I'm a big believer in, the providers work within our network, but so many other providers of these are good people. These are doctors and providers that want to do the right thing. When I say doctors, could include nurse practitioners or PAs also as providers. But when I talk about physicians, surgeons, specialists, these are people that want to do the right thing. They're busy enough; they don't need to do more. But the current fee for service system creates extra friction on top of the current friction for
Yeah,
them as well. So you have friction for the patient, friction for the providers, and then friction by design in the system itself that only benefits the payer. It doesn't benefit anyone else.
This is very interesting. I've been writing a lot about how AI creates trust issues and confidence issues, right? But you alluded to something that people don't say much often these days is there's a trust issue with the physician, like the person who is solving a problem for the patient, that the payers don't trust the physicians. That's a huge statement. I mean, if you boil it down, they're making billions of dollars in the current model, right? I mean, like the concierge medical services that you talked about, Blue Cross and United could do this tomorrow. Why wouldn't they? That's the question, right? Removing patient friction, if that's your goal on how to proceed in more complex scenarios, right? And we will go through that knee problem as we move along this podcast. But the idea is that, United Healthcare Group made $400 billion revenue, right? And 87% of physicians say prior authorizations raises their own total cost, even if it's a fee for service model. And we will talk about how fee for service model not only incentivizes the behavior that we want to eliminate, it also embodies the core principle of these payers that you got to listen to us. We know better and we don't trust the patient. We don't trust the provider, right? This is huge because in my adulthood, I lived in the UK for, good amount of a decade. And you go to an ER for a small checkup, right? I mean, let's say you have a bad headache, a PCP is not available, or they call a general practitioner over there. And you go to ER and you wait 48 hours sitting on that desk. It's not just a cost to economy, right? I mean, if I get paid hourly, I'm wasting millions of dollars across how many people who are waiting in ER to get their head checked out, right? So it's just not a problem with US healthcare. I think all the peer nations, they all have the same problem. And wouldn't you think it's counterintuitive anyway? I mean, so if you have patient friction that leaves the patients away from access to therapy and never seek care, down the line, it's going to cost you more. So isn't it in payers' interest to do this the right way in the beginning?
I would say yes. And if you watch the commercials, it's very clear they at least are trying to create this image of we care about the patients, but it doesn't fit within their paradigm. The message doesn't fit within their operating system.
Hmm.
So to go to them and say, hey, listen, let's just again go back to primary care because that's your one of the foundational aspects of
Hmm.
healthcare. There are a lot of really smart people and a lot of very fortunately hard-headed stubborn people had to fight to get direct primary care as a qualified HSA expense. That just happened like in the last year or so. Why did it take that long? Well,
Yeah.
it's because the insurance companies didn't necessarily want to have that happen because now that's money not flowing through their accounts. It's flowing now just directly through the primary care providers. So on that level, it's like, well, we don't need insurance involved on the
Hmm.
primary care level. And when you go beyond that, you start thinking, well, why do we need insurance involved to do imaging? Why do we need insurance involved for a stress test at a cardiologist office?
Yeah.
Again, it goes back to the premise of insurance was created originally for all the right purposes for catastrophic care. It has really become what we've allowed it to become in the US. This, massive entity that generates a lot of money that
Hmm.
controls so much of the healthcare dollar. And so now what
Yeah.
we found is okay, whoa, the pendulum swung so far over there. We got to stop this. Even people like Mark Cuban, not historically a healthcare guy, but he's been a patient.
Yeah.
He's in it neck deep now, right? Saying, hey, we've got to fix this. And it's not just a cost issue. It goes back to patients are the losers in our current healthcare system. They're going bankrupt. They're delaying care.
Yeah.
They're having to defer expenses in other parts of their life just so they can get certain very predictable things cost wise that shouldn't cost near as much as they cost.
Yeah, and I promised myself, while I was doing the prep for this interview, I was like, you know what, I'm not going to villainize insurance. I mean, they, as you said, I totally agree with you. They have a very important role to play. But when you just mentioned about those commercials, it boils my blood because I see those commercials in like biopharma companies. We love patients. We are here to help, and your insurance, your big provider networks. And then when you go in, going back to your knee example, it's all fragmented. And not that you don't have the best technology, not that you don't have the best physician, not that you don't have the best consulting mind in the world. you can fix it, right? So I want to deep dive more into that knee problem. 64-year-old Cadillac Insurance has a knee issue in day zero, right? On first month of this year. Her journey, when I simulated her journey throughout the US healthcare system, as you mentioned in the beginning, 30,000 plus artifacts generated that she never gets to see. About 10 to 15 EOBs, 5 to 6 patient portals that she needs access to. Meanwhile, she's going to work, she can barely drive, and she has to take care of her household. So the healthcare system in general is not supporting her. We have the best doctors, yes, and the best research facilities, yes, but the infrastructure is not there. So I'm going to bring you in to talk about how Longitude is helping to change that paradigm. So walk me through how the patient's life or that knee patient's life would change through your lens.
Absolutely. And Longitude Healthcare Partners, our goal was to partner with plans, partner with insurance plans, partner with tribes, Medicaid, whoever, just to say, listen, we're going to take the predictable aspects of healthcare on the specialty surgical level and create a direct specialty care model. So we're taking a similar concept to DPC, but now we're just doing it at that next layer of healthcare on an outpatient ambulatory surgical level. And the knee is such a great example because it's so
Yeah,
common, right? I mean, just
exactly.
that who doesn't have knee pain at some
I
point in their
have a
life?
I have a foot problem, and I told you about my own personal story
Yeah.
and how I still cannot do pain management because I don't have time to talk to 15 different people.
It's orthopedic issues are significant, and it's why we partnered with orthopedic surgery in our network because it's so common and so absolutely
Yeah,
crucial and important for patients. I did look at your algorithm; it's incredible. Just reading through that, I would tell
yeah,
anyone listening to this podcast, look at AJ's algorithm. It'll make your blood boil a little bit just seeing the
yeah.
complexity involved in one episode of care being knee pain. But how we handle a knee pain beyond primary care, and we look to partner with primary care physicians. We don't do primary care in Longitude. We're a specialty surgical outpatient facility network, and we operate on a per member per month basis. So for one fixed fee, we're able to cover a defined list of services based upon CPT
Hmm.
codes. And we do everything from outpatient imaging to knee scopes to shoulder scopes to urologic procedures to general surgery procedures, ENT, cardiology, GI scopes. It's all the most common things that you see beyond primary care. And
Hmm.
in the example, again, getting back to a knee is once primary care is exhausted everything at their level, they've said, you've had some knee pain. I thought it was arthritis. Examinations, this, x rays look like that. I think you need to see orthopedic surgery, is where things start to get really complex for patients. Okay, how quickly can they get in? There's your first thing. Patients dealing with at work presenteeism and absenteeism issues because they are struggling. And it definitely affects their ability to do things day to day
Yeah.
at home. It's just a quality of life issue that they begin struggling with substantially. But at the point they get in orthopedics, they have a copay usually higher than it
Hmm.
is for primary care. That's going to start hitting their deductible. They'll get more x-rays with
Hmm.
the orthopedic surgeon's office, likely an MRI at some point in time. If that orthopedic surgeon's employed by a hospital, that is all going to kick over to the hospital system. I will say, not to digress, one primary care physician is worth more to a hospital as an employee than ENT or orthopedics. Their ROI is better, and that's how important primary care is to a
Hmm.
hospital. But regardless of where they are, patients are generating costs for this continued workup. At the point, the orthopedic surgeon says, well, I'm going to do an injection in your knee here in the office of some steroid. There's a cost there. Finally, the follow up says, listen, we're going to have to do a scope. Clearly, there's something wrong with your knee. I think you have some cartilage. And so now you have to schedule that
Yeah.
scope. Hopefully, they have access to care there and it's not 6 months or a year before they get in to get that done. Now they get their scope done. There's tons of costs associated with that. Now they're going to get calls ahead of time. Hey, your deductible is this. You've only met this. You got to write us a check for $1,200 before you even can get the surgery
Yeah.
done. And then after the surgery, all the EOBs kick in from the facility, from the surgeon, from anesthesiology, everybody that's touching this in that surgery cost can be enormous too. Now, here in Oklahoma City, our surgeons utilize Surgery Center of Oklahoma, and I only mention that name because they're a freestanding facility that a guy named Keith Smith, MD, runs, and has had great success. He's nationally known, but the purpose behind this is wherever a patient goes is can we
Hmm.
have predictable costs? Well, in ours, it's not fee for service. All these things
Hmm.
are covered. So from the point they get referred to orthopedics through the
Yeah.
actual surgery and even outpatient physical therapy, everything's covered under that one PMPM. And so there's no EOBs. If the insurance plan wants to send it, says zero as to the patient cost and responsibility. There's no adjudication of claims. There's no repricing involved. And it's just a much more clean process. We're removing friction along the way through that process so the patient can get better access to care, streamline access to care. The surgeon doesn't have to hassle with a bunch of things. The facility doesn't have to hassle with a bunch of things. Therapy doesn't have to hassle with a bunch of things. We're just saying, I'm not there to manage how they do surgery. I'm not there to tell PT how to deal with post-op knee. Even as a physician, I'm really there to say your quality over here is going to be matched with the patient's needs over here. And we're going to remove so many moving parts in between that it's going to make life
Yeah.
easier for everybody involved. The only loser in ours is that PMPM dollar doesn't get run through the insurance plan. So the
Insurance. Yeah.
insurance plan may not like it because now they don't have control of that dollar.
And when I looked at your model, it attacks the right areas, right? You don't want to be doing primary care, makes sense. ER,
Yeah.
that's where insurance is for. You mark down the surgical points of the most friction oriented or friction prone areas of a healthcare journey, right? The simulated journey of a knee patient. Now, I want to switch now to a buyer perspective, right? So traditional insurance leans on pre-approvals or prior authorizations, right? So, and you have zero prior authorizations. The system is fixed fee. So how do you stop overutilization without, the usual guardrails as we talked about, where prior authorization was considered as a gate? So
Right.
how does that overutilization is taken care of in your model?
So I'll go back to like I think the 80s. I wasn't in practice then, like, even into the 90s, early 2000s. You had the HMO model was pretty
Hmm.
prevalent at numerous points way back then, and the HMO created a gatekeeper model, right? So primary care had to be the gatekeeper. And there was
Hmm.
kind of a per member per month thing attached to it, but it didn't work for a lot of reasons. One, there was way too many levels of administrative bloatedness to make a model like that work. And the dollars weren't flowing to the providers. It was really just being kept at the insurance level and trickling down to the providers to try and make this gatekeeper model work, which just was incredibly ineffective. And so it flipped back over to people got tired of that. This isn't working. And
Hmm.
so fee for service really started to gain some steam. You started getting these massive PPO networks and insurance companies. We're kind of like, listen, we try to do it this way. We'll just make it PPO so patients can go where they want to go as long as they're in your network. Your your primary care provider can refer you anywhere you want to go. Well,
Hmm.
big PPO networks are really expensive. And as much as they've been trying to make some differences in value based care,
Hmm.
there's still big gaps in value-based care, high quality care when you just look at a PPO network that's really, really broad. How do you manage that? And most of them aren't managed very well. How
Hmm.
how we work is more back to the gatekeeper model, right? So people are going to say, well, you're disincentivizing that surgeon from doing surgery because they're being paid a PMPM,
Hmm.
and so now the surgeon's going to say, well, if I do the surgery, it's going to knock down my PMPM. Well, we contractually address that. And also, if we have any providers in our network that are operating as such, that is certainly against contractually what we have agreed upon, and also will not be a fit for our network. Our providers
Understood.
are very happy with how we have this set up at this point in time. I've had very few no's, and the no's really aren't based upon they don't believe in the model. It's maybe outside of their current direction they're going business wise, or the parent company didn't ever kind of quite understand what we were trying to do. But the providers love what we're doing because they see where, okay, great, the patient gets to see me. I just get to make decisions now, not having to do prior auth, not having to call an insurance company. As I'm standing over the patient in the OR about to start my surgery and get justification to do the
Yeah.
surgery, I just get back to taking care of patients, and they love it. And they love it. We're real excited to continue to expand the network beyond what we have right now, but we have put in guardrails to make sure that access to care is at a premium and that there is no disincentivization.
Yeah, and this is very important framing. I mean, that was actually my next question is how did you get the physicians who are using fee for service model, right? From a commercial standpoint, you pay a steady monthly cash, which in all honesty, with all the issues with TPAs and RCM, if I were a physician, I would always want like a fixed income coming in that I can leverage for future expansion or whatever I want to do to provide better care for my patients. But was it hard to get Oklahoma specialists to walk away from traditional billing?
Well, in our model, because in direct primary care, when it's done right, basically they have to walk away from insurance model. It's kind of all or none. So primary healthcare partners, as I mentioned, their model is, hey, this is what you do. You got to walk away from insurance to do this, and it works for them. But our model allows for physicians to slowly integrate this into their practice. So we're
Gotcha.
not going to, one GI physician might be 20 to 30,000 patients in a population would keep them busy full time. Well, primary care, that's two or 3,000.
Yeah.
So we're not bringing 20 to 30,000 patients immediately to our providers. We're going to we're looking at pilots and we're looking at different relationships here in central Oklahoma to say, we're going to bring you a few thousand patients, but you can continue seeing your fee for service patients. You can continue doing Medicare, Medicaid. You can
Hmm.
continue doing whatever you're doing in your practice. Our hope is that you see this model being so advantageous for you, not just from seeing a patient and then getting back to that enjoyment of taking care of a patient without insurance
Hmm.
being involved, but also from a business standpoint that you have here's a fixed cost. Here's what you're making. We can compare it against numbers of Medicare, other insurance plans, et cetera. And it allows for them to say, hey, this is a great business model. Another thing, my business partner, his name's Ed Birtles, has brought up several times, and he's worked on this side of it for physicians, is when you're doing traditional practice, fee for service, whatever, your accounts receivable ensures that you're only going to get paid about 10, 11 months out of the year. There's always going to be a lag of a month or two,
Yeah.
always,
Yeah.
until
True.
you retire. There's always
Yep.
going to be a lag of a month or two. So in this model, basically we say you're made whole month after month after month after month. There's no AR. You're not having
And
to
has it
say, well, why is
eliminated?
my AR over 120 days at 10 grand? What's going on
Yeah.
there? There's none of that
That's a huge
exists
amount
in
of money. Yeah, that's a
yeah.
huge amount of money just sitting right there waiting to be recoded. So have you seen not having admin staff at these providers' offices who bought into your model? Like have they cut down those positions or they've started using technology more to provide better care? So I'm just assuming walking into a physician's office who is on that model and there's probably a front desk person just checking me in, letting the doctors know, and that's about it. Do you see that more often here in Oklahoma
Our
City?
goal is to AJ is to make this much more like that direct primary care experience that people have, right? They have access to the provider to ask questions. They go show up at the office, appointments start on time, appointments aren't rushed or hurried. Our goal is to get to that place
Okay.
for the members that are involved. That'll take some time
Yeah.
because it's specialty surgical outpatient care, the model has to be different than direct primary care. You can't
Hmm.
necessarily do it like primary care. If nothing else, it would just be capital and
Hmm.
very capital intensive to do that. It would just be so expensive to purchase all these practices and wait for
Correct.
patients to come. But it's really not necessary in this model. So we can begin that integration. Patients can start getting that streamlined care, and we'll continue to work on the model as it moves forward. Our providers, like I said, they're
Hmm.
excited to be a part of what we're doing, and it allows for them to just kind of gradually move into this. And I would say too, people say, well, how do you assure value-based care and all this? Yeah, we'll have KPIs and metrics, AJ, that will follow. Absolutely. But these are providers that are curated based upon my experience. And here in Oklahoma, these are providers that have seen my family members. These are providers that I've referred patients and friends to. These are providers that I've allowed to operate on me or places that I've been. These are high quality providers. I know beyond a shadow of a doubt because of my personal experience and because of my experience as a physician. And it's overlooked everywhere. People talk
Yeah.
about, well, how do we ensure high value care? I was like, have you asked primary care providers?
Hmm.
Ask primary care providers
True.
locally, not hey, of the 10 surgeons that are employed by the same hospital system that you're in, which one would you use? It's community wide. Which surgeon would you use for X? Which
And
specialist would you go to for
never
Y?
use your insurance star rating. That's for sure.
So if you just ask the providers in any community, they can tell you here's who we recommend.
Yeah.
And I would put that up against any value-based metric.
Yeah. It's just like finding a good lawyer. I mean, I'm an attorney. right? So the only way as an attorney you get business is by word of mouth. And you're right. I'm just waiting for you to come here in Arizona, right? That may be a long way, but this is how we scale, right? I mean, you have to have a gold standard for practice, like how a value-based care. And that's a whole another topic that I think you and I should do another podcast on is value-based care and what does that mean
Right.
for the real person on the ground, right? We want to really do this to enhance the services that you as a doctor have spent decades on learning and experimenting and providing the value based care that you always wanted to. Now, I want to talk about the employee commercials, right? The insurance plans who are looking to buy into this model. Now, legacy insurance can plan for spikes, right? They can, model some of these, but you have a fixed cost based on the CPT codes. So when you talk to a CFO, what is the biggest hesitation when you pitch this and say, you know what, you just pay X amount of dollars and you all sorted. You don't need to worry about this. And how do you handle those conversations?
Absolutely. One of the things that we learned years ago, so Ed and I, with a group of other investors, actually tried this model out about 12 years prior, well over 10 years ago. And we had some success in getting patients onboarded. The
Hmm.
problem was it was a concept before its time. DPC was in its infancy, just starting to get interest, especially here in Oklahoma. And but we saw that it worked. Our model worked. What we were paying the providers worked. We had one specialty area that we had to adjust slightly for a couple different reasons, but it was a very simple fix. We adjusted it. They were super happy with what we did, and we knew that it worked. The problem was is that we didn't really understand who our customer was at that point in time, because our
Hmm.
customer ultimately is, yes, do we want to make the CFO and CEO and the HR department at any company happy if they're using a plan that includes our network? Absolutely. But ultimately, our customer is whoever is designing the plan, not even necessarily the brokers and the companies that brokers are representing who are putting these plans together. So on the employer sponsored insurance side, it's those people that are our customers. Now, if the CFO has questions about from their standpoint, what if there's a spike? Well,
Yeah.
we're insuring already. We're not insurance. We've already had a legal opinion on that, but we're not insurance. But we are guaranteeing that we cover these things. So it's on us, and we feel very confident in
Hmm.
our numbers. And again, we have a precedent because we did this before. We have a precedent saying we're confident that our numbers will work, that we can absorb any spikes over the course of a year within the current setup on our PMPM structure.
So
And
would it?
so for the CFO, if you're running a self-insured plan, those spikes hurt, right? You're just
Yeah.
like, "Oh, wow, we had this, and this year.
Yeah.
We had 30 more MRIs than what we thought we were gonna have. We had 8 more knee surgeries than we thought we were gonna have. Those hurt." Well, in our plan, we're taking that responsibility away from you, and it's covered. So you don't
So,
have to worry about those spikes. Now, if there's a transplant or there's ER visits, there's hospital, inpatient, the
yep.
big ticket medical items, yeah, that's on them. We're not solving.
For
We're not coming
everything.
here
Yeah.
saying, "Hey, we have a solution for everything in healthcare."
Yeah. Yeah.
Healthcare's big, it's complex. We're saying we're going to take these predictable aspects of what patients need beyond primary care on an outpatient, ambulatory, surgical level, and give you a fixed PMPM for that. Beyond that, then they can go to insurance for those other needs that
Yeah.
they're going to have.
So would it be too much to ask to talk about how does that model work, or will that be too much of a secret sauce spillover?
Yeah, there's some secret sauce components to that as well, for sure. And so I can't get into how exactly our methodology
Yeah.
works, of course. But for our partners, we're able to provide a lot of details in regards to here's what we do,
Hmm.
here's the numbers you're dealing with, and we even have a couple that are looking into comparing our numbers to historical data that they have, which we totally welcome. We did this 12 years ago, and without saying who or when or what or where, we showed for a group of 6,000 people savings of over $2 million,
Hmm.
assuming 100% utilization of our network, adding back in the cost of our network. So
Hmm.
we know it works, and not a lot's changed in many ways since that
Yeah.
time. There was about a 24% cost savings on the plan if they had included our network versus how they were doing on a fee for service basis. So yeah, we have a couple people looking into doing a little deeper dig in there, and yeah, they're happy to sign an NDA so they can get that work done, and we're happy to help them feel comfortable with making this
Yeah.
decision. It's a paradigm shift in
Yeah.
regards to how they're designing their plan. It's not just shifting cost around. It's not just, hey, you have fee for service, but we're going to do direct contracting versus run it through the insurance company. We're just saying, let's just change all of that and move it over to this pile over here, and we think you'll be real happy with the results.
I mean, I'm assuming that I think the only, as you said, right, the only unhappy stakeholder in this will be the insurance, but everything else is it's literally a paradigm shift in the mindset on how we approach and see access to patient care and how much we value that, right? So I want to talk about, and this raises an important question for this segment, which is the tribal health and Medicaid. Tribal health is not really talked about much, and you're also focusing on that. The budgets are spread too thin as it is. So how do you have those conversations, and do they see the same level of excitement as employer commercial, where they're seeing better access to care?
That's a great question, and these are three different segments that we're looking to tackle. Employer-sponsored healthcare and the way we fit in is very different, of course, than Medicaid and
Yeah.
then tribal nation health plans. As far as the tribes are concerned, access to care has chronically been a challenge for them. They have a preferred referral system, a PRC system that they use to determine, okay, who gets what care beyond primary care. Here in Oklahoma, a lot of the tribes are working on having improved access to care, starting with primary care and mental health. There remains challenges for them getting providers. They're trying to establish, some of them have some beautiful clinics and buildings that they're building out. But again, getting those providers and specialist
Yeah.
surgeons to come into that can be a challenge as well. And
Hmm.
then, if a patient is in a place called Shawnee, Oklahoma here, which is about 45 minutes from the city or so,
Hmm.
to tell that patient, hey, you need to go see a cardiologist. Here's where they are. If they don't have a car, or that
Exactly.
cost of gas, which isn't cheap anywhere,
Yeah.
is an issue. They're not going to make that appointment. So you have to have some facilitators in place there to help them get past that. But on the tribal health side, this creates, especially in their PRC system, a
Hmm.
very fixed, predictable spend for 80 to 90% of what their patients are going to need beyond a primary care on an outpatient basis.
Hmm.
For Medicaid, you're really looking at, like many states, looking at the managed care organizations. In Oklahoma, there's three: Centene, Aetna, and Humana. And we're just now beginning that engagement with these entities, looking for a pilot that would allow for us to take on a certain number of lives. I think here in Oklahoma, there's 800,000 lives that would qualify under our plan. We don't do pediatrics, we don't do Medicare age, but we're not going to take on 800,000 lives, and that wouldn't be very effective because a patient that's in Tulsa or in
Hmm.
Lawton or up in the Panhandle, and our providers are here, wouldn't work. That being said, that pilot will allow for them to have some time to take a look at the numbers, access to care, look at the KPIs and metrics that we'll provide to them, and provide them based upon what they want and need to see. And then, of course, dealing with the regulatory aspects of this with Oklahoma
Yeah.
Healthcare Authority. We're working all these things out right now. We've seen absolutely no hurdle or obstacle come up that says you shouldn't do this. And it's interesting,
Hmm.
when we first put this together, my partner and I, and revisited this, we tabled it about 10 years ago saying, listen, this works. The market's not ready for it, right?
Yeah.
And any businessman knows it doesn't matter how great your concept or idea is. If your market's not there for it, then it's never going to take off. So we tabled it. We knew it was going to work. And when we first revisited this, AJ, it was because the state was looking at managed Medicaid contracts, and they were changing some of the law. The Oklahoma Healthcare Authority was going to be turning this over to the managed
Mm.
Medicaid entities. And I talked to them, a representative who said, your plan is the best one we've heard. Another
Wow.
representative who said, no one else has come to us with solutions. Your plan works. And
Yeah.
we had partners here in Oklahoma that said, hey, we'll do the primary care side if you want to do all the specialty surgical side. But it was already kind of predetermined it's going to be turned over to the insurance entities. So we're looking at being a major subcontractor with one or all three of them to say, let's carve out a particular population here in central Oklahoma. Here's what we provide. Here's how we're going to work to engage them. They have patient navigator working with them. And our goal is to make sure that they get access to great care. And
Yeah.
I know already the providers on our network provide great care.
Hmm.
And our model allows for that access that many of these patients have struggled with for decades.
Yeah. And if you take Carom Health, for example, right? I mean, They bundle surgery together straight with employers, and they've served 7 million members now. So going around the carrier isn't really new, but I think what you are doing is not one procedure at a time for a flat monthly fee across whole range of specialties. And I think that's what's missing from the industry at the moment. And I'm so happy to hear that you're getting amazing responses from people who need this the most. So I want to ask you this. So make the case. So does this scale like Amazon or does it stay boutique?
It absolutely scales. If for no other reason, it's you're providing healthcare, AJ.
Yeah.
So anywhere people need healthcare, this model works. We can take this model anywhere in the US. Now, a rural model that includes our network would have to be structured differently. But again, rural
Correct.
healthcare we know operates differently, has to be treated differently. And there's a lot of money coming from the federal government to try and fix numerous aspects of rural healthcare right now. But from a metropolitan area,
Hmm.
I can scale this to Kansas City, I can scale to Chicago, I can scale to Scottsdale. We can take this anywhere. There would be a model in place as to how we would roll that out in each local community, the people that we would look to partner up with in each community. And we're excited about that potential and possibility. It's obviously a natural fit for us here in Oklahoma for a few
Yeah.
reasons. One, I'm here, I know the providers, so we can really fine tune this model here. Also, the Oklahoma managed Medicaid
Hmm.
status and what we're dealing with right now, it actually fits within that. And of course, we have 39 federally recognized tribes here in Oklahoma that could benefit from this as well. Employer sponsor health insurance over the last 10
Yeah.
years, we've seen a lot of growth in innovative models
Hmm.
to help people become level funded or fully self funded. And so we're having numerous conversations looking to partner up with them and be part of a plan, one of several options that says, hey, this particular plan, if you choose it, you're going to have this network. Here's how it operates within that plan. So we're excited to get it off the ground here in Oklahoma. And then we will absolutely be looking to scale once the timing is right for that.
Yeah. And if you move to Arizona, I'm your guy. Hit me up. But
Okay, awesome. Great.
because I mean, I am extremely dedicated towards patient experience and not even patient experience. It's more about giving them the right tools to navigate this journey, right? And you have to empathize with the patients and help them because they don't have $1 billion standing with them,
Mhm.
going through admin costs and whatnot, right? Now, in your world, like what does that 2030 vision looks like when are you seeing any major headwinds from regulation, from capital, from incumbents like Amazon decided to do PillPack, One Medical didn't really go that far. There is some wisdom to be had to fine tune your model in Oklahoma City and then scaling it out to create a more repeatable and scalable
Mhm.
process. But what are the major sort of constraints that you feel are going to be the biggest challenges that you face in the next 5 years?
Uh, Great question. On again, going back to different sectors on the employer sponsor healthcare side and self funded plans, the direct contracting that has evolved so
Hmm.
effectively everywhere is definitely a competitor in that sense that we're competing against a network that already has direct contracting. So our model doesn't include copay, deductible, et cetera. Well, neither do a lot of these. And so kudos to all those people that are working on trying to help patients get better access to care, trying to save on costs, because those direct
Hmm.
contracting models have done that. I would still argue again, it's fee for service. There's a lack of predictability and cost for
Hmm.
whoever's putting the bill for the plan, and so you still don't know where the spikes are going to happen and what you're going to spend on anything any given year. It's a move in the right direction, but as one national player, indirect contracting told me, guy out of Las Vegas
Hmm.
said, "You are the future of specialty
I
surgical care.
agree.
This is an evolved model," and we believe so too. As far as Medicaid's concerned, again, a pilot here in establishing that we are effective, that we do those things that we know that we're capable of doing as far as providing access to care and meeting all the regulatory requirements involved. Once that we can begin to expand that, and then we would love to look at taking this to other locations across the country. We have a new partner. I'm not bringing his name out yet, but we're real excited about him coming to us with his Medicaid expertise and all of his experience that he brings in regards to saying, here's how this can work for Medicaid. And then as far as the tribes are concerned, again, same situation. We get a pilot, we make it work for them. We work out any of concerns that they might have. we'd love to take this to all 500 plus tribes across
Yeah.
the US to get them access to care.
Well, that's a whole lot of work, and I think you have the work cut out for you. And I think it doesn't matter which way you cut this pie, right? I mean, it's really boils down to me and my co-founder Neil. We coined this term called TACI, 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 which is directly related to patient with time doesn't have time, doesn't have authority, doesn't have an incentive, and doesn't have control or insights over their own healthcare journey, right? So any model, for example, yours, actually provides that TASI back to the consumer and say, you know what, we will use technology, we will use modeling, we will use connections to get you the frictionless access that you need to get you back to your time, your authority over your own records, control over your own life and your health decisions, and insights into where your journey is progressing to. So I love your model removes that friction, but I think what you can do potentially is to start layering on technology solutions to your members and say, this is how you take control. The care navigator is going to help you walk through different appointments, but what if there's an orchestration layer, right? I talk a lot about AI and how AI is changing lives and supposed to be changing the workflows that have bogged us down for decades. And maybe you can layer that on top of your service offerings when you're talking to ECAs and tribal health programs and say, we will allow your seamless integration for your members to get a better and more enhanced patient experience. So it's something that you can take back. Now, I'm just going to, go on to the last hard one, summarizing everything we just talked about, right? What's the thing about American healthcare everybody nods along to and says it's broken? And you think it's just plain wrong. And I want your unfiltered answer. Of course, I'm sure like from your position, you may not, but as best as you can, what's that one thing with the current system that's just plain wrong?
One thing that's just plain wrong with the current system. It goes back to why I'm here talking to you, AJ. It goes back to why we established
Yeah.
Longitude. In my opinion, the one thing that's wrong with the US healthcare system is that we have created so much complexity between the patients and their access to care. And insurance, I said at the beginning, I'll say it again, insurance is absolutely essential. But the one thing that's wrong is that when we create so many layers of complexity between the simplest aspects of people receiving healthcare, all it does, it drives up cost. That's all it
Mm-hmm.
does. The more touches between a patient and the
Insurance.
more
Yeah.
touches on the healthcare dollar between the patient and and whatever care they're getting, all it does is increases cost. The
Mm-hmm.
quality of care is not going up. The access to care isn't going up,
Yeah.
but it's just increasing costs. Complexity has to go away for those things in healthcare that are relatively simple and predictable. And that's not just primary care. It's not just mental health, even. And it's not just simple prescriptive aspects of PBMs,
Mm-hmm.
but I'm talking about cardiology outpatient, GI
Yeah.
outpatient, general surgery, orthopedics, ENT outpatient, imaging outpatient, lab outpatient. These are simple parts of healthcare from a provider standpoint.
Mm-hmm.
Let's remove the layers of complexity that have been created. Let's let insurance keep doing what they do great in regards to dealing with catastrophic care. And we'll see the cost of healthcare go down. But more importantly, we'll see access to healthcare and those and quality metrics.
Well, that's a great answer, but I think one thing that's not said out loud is what you're talking about, either compression or removal of these additional access layers or these complex problems. There is a special interest, right? That's never going to let it be a pan American thing. There is billions of dollars being spent in lobbying to make sure that that doesn't happen, right?
Yeah.
So I think one of the challenges, and I think as we progress through this and see how a PMPM model improves access and people start seeing the impacts of it on overall healthcare numbers that we should be seeing. Until that happens, I have a very pessimistic view of how these special interests are going to be overtaking the conversation, overtaking those important discourse in public spaces. This is why this conversation is important to really
Yeah.
create that space for us to have a conversation about boiling it down, boiling everything, every interaction down to how does it impact the patient, right? Once you start looking every single decision from that angle, you are now working extensively for the patient.
Too many middlemen. There's
Yeah.
just too many middlemen right now in healthcare that don't need
Yep.
to be there, that don't improve access to care, that don't improve
Correct.
quality of care, that do nothing for the patient. That
Talk
they
about the
just do
switches,
nothing for
right?
the patient. There's a reason
Yeah.
why patients have a 33% trust of insurance companies,
Yeah.
but they still have a 90% trust of physicians and providers in general, nurses included. Patients still trust what we're trying to do, but
Yep.
they're fed up with the system as it is. And so the hope is that, people like you, AJ, people like myself, and tens of thousands, if not hundreds of thousands of others that are really looking to move insurance back from that pendulum swing that it's done with
Yeah.
controlling so much of the healthcare dollar back
Hmm.
towards a healthier middle ground. The hope is that we can continue to make way, but you use the word headwinds, there's very strong headwinds.
Yeah. And more power to you. So before I let you go, where do people find you and what should they read first to understand the problem?
Yes. So our website is longitude.healthcare, and that explains the different various aspects of what we do, the specialties that we're covering. Again, we're located here in Oklahoma City, but this is obviously a very scalable model that if we had lives, we would love to look at going to different locations. We're not prepared for that yet, but that is definitely on the horizon for us. My email is david@longitude.healthcare. Anyone's welcome to reach out to me, ask questions, or if they want to set up a time to visit about what we're doing, we're happy to answer questions. We're really excited about doing our small part in helping to make healthcare more affordable and more accessible.
Well, thank you so much, David. So, David's bet is simple: keep insurance for the catastrophe, get it out of everything else. His work is in the show notes. Subscribe on Substack, follow on YouTube. Next episode, same fight with a new guest. This is the Hub Brief. I'm Ankur Jain. See you there.